Evening to one and all. It gives me immense joy to welcome you all to the 9th session of the Cardio-Obstetrics Master Class series. So today we'll be delving into another complex yet a vital topic, balloon aortic valvotomy in pregnancy. I now request Dr. G. Justin Paul, sir, the course director of the Cardio-Obstetrics Master Classes, to give a brief introduction about this Cardio-Obstetrics Master Class and lead us into today's topic.
Dear, good evening, dear one, all of you. We really are so happy that you have joined. And this is the 9th edition of Cardio-Obstetrics Master Class. The very idea we started this master class is to ensure that those of us who are managing high-risk pregnancy, particularly in women with the heart disease, we are very familiar with all complex scenarios so that subsequently we have a case like this, we give the best care to these patients so that the maternal mortality related to heart disease will start coming down in our country and will be contributing to reduce maternal mortality in our nation. This noble idea, this is one of our ventures that we have started, and thank you for being with us all along. Today we are dealing with the case of balloon aortic valvotomy in pregnancy, not a very common scenario that all of us may be facing our day in and day to life, but definitely we'll be seeing a lot of patients with aortic stenosis, mild, moderate, and severe, some of them with symptoms and some of them without symptoms. We really need to know how to handle these scenario. So we are having today, we are so happy and we welcome the team KEM Hospital, Mumbai, who are presenting one of the complex cases they have done, a case of severe aortic stenosis for which they had to do a balloon aortic valvotomy in pregnancy. So what are the lessons that we can learn from these cases? And what are the contributions that we can give as a panel, faculty, as a panelist or a faculty or as a member? Because the chat box is open to all of you. You can, if many seniors will be there, you can share your inputs, and juniors, you can definitely ask your doubts. We'll try to address all that in the Q&A session. As usual, we'll have the case presentation, and there'll be 3 discussion breaks in between where the panelists will answer. And finally, there'll be a small talk on our take-home message on managing aortic stenosis in pregnancy, during pregnancy. With that, I hand it over to Dr. Bhavik.
Good evening, everyone. I'm Dr. Bhavik Shah, and I work as an assistant professor in Department of Cardiology at KEM Hospital. Thank you for the opportunity for today for presenting this case to all of you. So our patient is a 30-year-old female. She presented to us at 10 weeks of gestational age, and she was G2P0L0A1. However, initially patient did not reveal any history of cardiac disease. Upon probing, patient revealed that she was diagnosed to have cardiac illness during first pregnancy in 2023. Of which the details were not known to the patient or to us because there was no proper documentation available when she presented. And like when we tried to further probe the patient about what had happened in the past, she said that she had undergone medical termination due to cardiac illness. However, there was just a scribbling over there, which was written that there was medical termination was done in 2023, and there was no details what was the problem at that time. The patient had then lost to follow-up for last 1.5 years, and now she presented with NYHA class 3 dyspnea to us and with some history of cardiac disease. Next slide, please.
Next slide.
So the patient was admitted and evaluated, and on clinical examination, she was conscious oriented, not dyspneic at rest, and there was no pedal edema. Vital signs showed that the pulse was around 100 pulse beats per minute. Blood pressure was 110 by 70 millimeter of mercury. Respiratory rate was normal, saturation was normal, and JVP was not elevated. On CVS examination, there was a harsh crescendo decrescendo ejection systolic murmur 3/6 in the aortic area with late picking, and the ECG showed left axis deviation with kind of a poor progression of R wave with broadish QRS around 110 milliseconds. So we took her for echocardiogram. Next slide, please. On echocardiogram, there was no RWMA. The dimensions of left ventricle were 30 millimeter in systole and 42 millimeter in diastole, with 60% ejection fraction. The LV systolic function was normal, and the short axis, high short axis, showed bicuspid aortic valve with fused RCC and NCC. RAFE was at around 10 o'clock position, and the gradient across aortic valve was 128 by 82 millimeter of mercury, and the AV Vmax was 4.7 meter per second. There was mild pulmonary hypertension, and patient was in sinus rhythm. Can you please play the video of the valve? This is from one of our archives. We didn't get a better view of the short axis. You might think that the valve is opening well, but this might be an oblique view where the valve was cut obliquely. However, the gradient showed that it was a critical aortic stenosis with high gradients across the aortic valve, and the patient's symptoms were correlating with the echo findings. Next slide, please. So to summarize the diagnosis, when the patient presented, it was documented that she was primary gravida, even though we found that there was a history of MTP 1.5 years back. But we earlier, when she presented to us, we documented as that she was primary gravida. At 10 weeks of gestational age, congenital bicuspid aortic valve with symptomatic severe aortic stenosis. The LV systolic function was normal. The patient was in sinus rhythm with mild pulmonary hypertension. So that was the provisional diagnosis that we got. So this is the poll for the audience.
Aparna, you can launch the poll. Dear audience, we have a question here for you. Aparna, are you there? Can you launch the poll?
Yes, sir.
Symptomatic severe aortic stenosis in 10 weeks' time. 10 weeks of gestational age. Should you continue pregnancy or should you terminate pregnancy? The poll, somebody is able to answer or not?
Yes, sir. No, sir. The options will come in the non-host, sir.
Okay, right.
Good, sir.
But nobody has answered it. Yeah, now they are starting to answer. Audience, I hope you're able to answer the poll. Are you able to see the poll?
Yes, sir. We are able to see the poll.
Okay, fine. So both the questions are seen now, I think. So which MWHO category this patient belongs to, and how should the patient be managed? 10 weeks, symptomatic severe aortic stenosis. Should we continue the pregnancy or terminate the pregnancy? And which MWHO class 4 she becomes? I request all of you to kindly poll, choose your, make your choices. Yeah, I think you can show the answer in the next. Yeah, since there are 2 questions other, we'll give that full time to them. Yes, Aparna, you can just close the poll and show the answers.
Yes, sir.
So as we can see that, majority of our participants have voted for termination of pregnancy. And they have called it as modified WHO 4 classification. So, well, it is right. And we'll have this as a discussion. So maybe we can stop sharing the slides and go to discussion. And I have some questions now, maybe to our obstetrician friends, then our cardiology colleagues. Maybe the first question I'll ask, I think, Dr. Himangi.
Yes, sir.
Hemangi Kansaria.
Yes, sir.
If the patient was seen before pregnancy, what kind of preconception counseling you would have given?
So she should be referred to cardiology for consultation and she'll benefit immensely from counseling. This reducing complication during pregnancy and optimizing cardiac function is the goal. This life-threatening condition can be reversed by corrective surgery ideally and definitive surgery prior to pregnancy. This should be explained to the patient.
Right.
And
I think you are right on the spot on. Dr. Hemangi has very clearly said that this kind of patients, it's always good to have a discussion with the cardiologist and the obstetrician. Joined together, they talk to the patient, and the patient is severely symptomatic. She has rightly pointed out that the patient needs to be heart disease needs to be taken care before we allow her a safe pregnancy. Thank you. I'll ask one more question now. Now that the patient has come to you pregnant, and she is 10 weeks into pregnancy, would you suggest to continue the pregnancy or terminate the pregnancy? You also saw the audience polling for it.
So since she's NYHA class 4, it's better to terminate the pregnancy since she has come to us early in pregnancy. She has come to us before 20 weeks pregnancy, which is basically a legal gestation age for MTP. If she comes after 20 weeks, then ideally cardiac intervention is necessary.
Please go ahead.
And she may require prolonged, if she comes after 20 weeks, she may require prolonged hospitalization or bed rest. Depending upon the case, she might require cesarean section. In labor, when she goes in labor, she should be kept in proper position. Vital signs should be taken frequently between contraction. And if there are signs of ventricular, if pulse is more than 100 during respiratory rate more than 24
We'll come to
beats
that,
per
doctor. I
minute.
think right now we are in the 10 weeks.
So she requires MTP, yes, sir.
Good. So maybe I'll ask Dr. Charan, our cardiologist, what will be the advice you give for a woman with severe AS, just broad severe AS, who's contemplating pregnancy? You're muted, Dr. Charan. You're muted, Dr. Charan. Dr. Charan, Dr. Himangi is a professor of obstetrics and gynecology at KM Hospital, Mumbai, and Dr. Charan is a professor of cardiology at KM Hospital, Mumbai.
Yeah. So, can you come again with the question, sir?
If the patient comes to you with severe aortic stenosis, the same question that I asked the obstetrician, here whether symptomatic or asymptomatic, either way, is there any difference in the way you manage them? How will you manage them?
At the 10 weeks of gestation, patient coming with us with severe AS and having a class 3 symptom, it become a very symptomatic patient to us. So if you assess clinical, first we assess the clinically what really patient is symptomatic, who has a class 3 symptom of breathlessness. So according to it comes in the high risk kind of a group to get further either for the MTP and then followed by maybe the balloon aortic procedure. So assessment is mainly depends in that period about whether the patient would need something maybe invasively. So that decision depends on the symptoms and the patient presentation. So in a severe AS patient, generally symptom status are either NYHA class more than class 2 symptoms, which are statistically significant symptoms. Patient can have symptoms of arrhythmia like atrial arrhythmias and a history of syncope or angina. This is one clinical criteria where we can assess the clinical status of the patient. Another thing, what gestation the patient is presenting. Yes, in early gestation, that is at 10 weeks, we have a lot to offer to the patient, right? She's in the legalized period of MTP. So definitely as she is a symptomatic severe AS, we will assess by all the tests what has been done, and Dr. Bhavik has already talked about how to analyze the patient clinically by doing ECG, echocardiography. Then we decide the severity, and then we'll proceed after doing the cardiac teamwork approach, what is most important for the patient at that point of time. So definitely this patient will offer her.
I have one more question for you, if you permit me to ask that question also. If the patient comes to you before pregnancy and she's totally asymptomatic severe AS, would you consider an exercise testing or a BNP to assess her or you will straight away say she needs a surgical correction?
Yes, sir, definitely. I think asymptomatic severe AS patient, by different guidelines also what mentioned, that patient can go ahead and should go ahead for the exercise test. Exercise test is what tells us is one important thing, a high-risk group of patients identified by 3-4 important criteria. One is whether patient becomes symptomatic on a stress test, exercise test, either by maybe angina, syncope, or a breathlessness. Second thing is the patient gets hypotensive, more than 20 millimeters decrease in the blood pressure on the stress. That is one sign. And also exercise-induced arrhythmias can happen. So these are three important things which we can tell that patient is now become symptomatic on stress test, and that can become an indication for the surgical indication or a non-surgical intervention.
Thank you, Dr. Charan. So from the discussions of Dr. Himangi and Dr. Charan, what we understand that is, if the patient comes to us before the pregnancy, and if she has a severe aortic stenosis, if she is symptomatic, the patient needs to be treated for the cardiac condition before she goes in for a pregnancy. Now, if she's totally asymptomatic, then you can put her through a BNP testing. The BNP is normal, exercise stress testing is normal, functional capacity is very good. Then there is a role of continuing, allowing her to go through the pregnancy. Now let me ask Dr. Hemangi Warke. So how will you comment on the maternal and fetal outcome of these patients with severe aortic stenosis? And maybe you can also just make it already, I think the risk status assessment has been covered. You probably can comment on the maternal and fetal outcomes of patients with severe aortic stenosis.
This patient is in YCH3 as well as in the modified WHO class 4. So she poses an extremely high risk for maternal mortality as well as morbidity. Now, coming to the maternal risks, the main risk in this is would be sudden death or even a heart failure. And this is very important during the need to take care during the intrapartum as well as the postpartum period for this. Also, as Dr. Charan has already highlighted, symptoms of angina and syncope may frequently occur, and these patients may even have arrhythmias. But the most foremost and the dreadful complication is sudden death and irreversible heart failure. So that is about the maternal complications in brief. Coming to the fetal issues, these patients, because of decreased placental perfusion, they can have low birth weight, intrauterine fetal growth restriction, as well as preterm labor. Also, few of them come in spontaneous abortions, or because of placental hypoperfusion, they may have a fetal demise. The incidence of low birth weight or preterm labor is seen to be around 25 to 30% in these patients.
Thank you.
So, antepartum surveillance and good monitoring with the backup of cardiologist and a multidisciplinary team will go a long way in having a good maternal and fetal outcome.
Thank you, Dr. Himangi. And Dr. Chandraban Meena, Professor and Head of the Department of Cardiology at SMS Jaipur Medical College, has given his comments that very high gradients, like more than 5, often direct surgery is always better. There is a point because many consultants use that as a guideline. But often what happens is those patients with very high gradients, or also they failed the exercise testing and as well as the NT-proBNP. So that is also something that is very good. Thanks to Dr. Chandraban sir. Thank you so much. And one of the question is, how many will do the TMT as a private OPD for a severe AS? Very valid point, Dr. Dharmesh Solanki. It is practically difficult to get a treadmill exercise testing done there in a private lab that we are not supposed to do. This is supposed to be managed by a cardio-obstetric team, where there is a team of cardiologists and obstetricians working together, discussing everything with the patient, and a supervised treadmill can be done in the hospital setting. So thank you so much. And Dr. Biswajit, I think thanks for sharing inputs there. I think very good, Dr. Biswajit Mujindar from Calcutta. Thank you so much. Now, thanks a lot for the audience. I think we really appreciate the audience participation. And thank you so much. Continue to share your inputs. And Doctor, I think Bhavik will continue with the case. before we take a next break?
As discussed, we have done the obstetric risk stratification. The patient presented to us with NYHA class 3 dyspnea. There was no further exacerbation after admission. The patient was classified as MWHO class 4. We have also used Zahara score and Cardiac 2 score. According to the Zahara score, it was 3.25 and the maternal risk was around 43%. Same with the Cardiac 2 score, where the score was 5.0, which corresponds to around 41% of maternal risk. So the important part is that when you club aortic stenosis with NYHA class 3, the maternal risk directly jumps from 10 to 15% to 45%, approximately 45%. So the patient had approximately 45% of maternal risk adverse outcome. Next slide, please. So the patient and family were counseled, maternal and fetal outcomes were discussed, and the patient was not willing for continuing the pregnancy after we showed all the pros and cons of continuing the pregnancy. The patient wanted termination of pregnancy. So there is this poll 3.
Yeah, come for the poll.
Aparna?
I can launch the poll. Meanwhile, one more clarification is that in aortic stenosis, more than exercise ECG, it is the exercise echo that is preferred, where you can do it in a more controlled setting. But both can be done. Please, I think audience, I hope you are able to see the poll. I request you all to kindly participate. So 2 questions are there. I think the same questions. I think all are coming together. I think all are coming together. I think something wrong in the way we assess that. I am sorry about that. But 3rd question and 4th question you can probably answer now. The patient is 10 weeks pregnant and planned for MTP. Does she require an balloon aortic valvotomy before the procedure? Number 4 is which are not the red flag signs of aortic stenosis during a pregnancy? So these 3 and 4 you can answer. The rest of it we can answer subsequently. I think 1 and 2 we had covered earlier. All of you have answered 1 and 2 is right.
Yeah, it's not allowing to submit, sir, if we don't answer all.
Oh, is it? Okay. We are so sorry about that. I think this time we had used a different source to construct the questions. Okay. Maybe you can answer all. We'll take the discussions in the right time and you can answer all. The 5th question is, the patient underwent a BAV. The gradients are still unsettled. What will be a treatment option? Will proceed with the MTP, continue the high-risk pregnancy, or both may be options or not? That's the 5th question. So we'll wait for another 5 seconds and then we'll close. You will stop the poll now. Yeah, share results. Yeah, we'll have a discussion now. Next slide you can move, or you can stop slides. Now, maybe I'll ask the question back to the obstetrician again. Now, after all these things, can you go to the next slide? Annie, can you move to the next slide? Yeah, please. Doctor, you can present the case.
Okay. So next slide, please.
The previous slide, I think there was one previous. It's the next one, I'm not sure. Yeah, next.
Yeah.
Welcome,
so after a detailed risk-benefit assessment was carried out, the risk of maternal hemodynamic collapse or sudden cardiac arrest during pregnancy was explained to the patient. She was offered balloon aortic valvotomy as a bridging procedure to stabilize her hemodynamics and permit safer anesthesia for termination. So the plan here was never to continue the pregnancy. The patient wanted termination. So even with such high gradients, we offered her BAV so that the gradients may come down a bit, and the obstetrics team might be more comfortable in doing the termination of the pregnancy. Next slide. So the patient, after the
We'll
discussion,
take a break now, Doctor. We'll take a break now. So maybe I'll ask Hemangi Kansaria.
Yes, sir.
Now that the patient wanted MTP, when will you plan MTP? She's 10 weeks now. And what method would you use? This for the benefit of the obstetricians and also for the cardiologists to whom, like many of us cardiologists are a little unfamiliar with the techniques of MTP. And suddenly, we may be asked by the obstetrician, what will be a better method? So it'll look Greek and Latin for me, but it is very reassuring if we all think in the same line. So Dr. Himangi, can you please share your inputs?
Yes, sir. So here in India, we carry medical termination of pregnancy up to 9 weeks, but in foreign country, it is done up to 12 to 14 weeks medical termination. And there are two methods, either by medical methods or surgical methods we can terminate. Medical method, mifepristone 200 milligram is given after 36 to 48 hours. After that, we give misoprostol 800 microgram vaginally. And surgical method, there are 3 types of surgical method: manual vacuum aspiration, electric vacuum aspiration. So we can do either medical or surgical. Since she's 10 weeks, it's better to go ahead, because in India, it's medical termination is allowed only till 9 weeks. So we can go for surgical method. The pros and cons of medical methods are it avoids surgery. It's basically just a patient has to take medication, but it takes time. It can cause nausea because of the drug side effects. It can cause nausea, vomiting, diarrhea, chills, fever, and abdominal cramping. While a surgical abortion, it takes usually in a tertiary care hospital, it takes place in a healthcare facility. Patient is under anesthesia, so though no discomfort or cramping as such, but it requires surgical insertion of surgical instrument. So both methods are that way good, but since she prevented at 10 weeks, it's better to undergo manual vacuum aspiration, that is surgical method.
Thank you, Doctor. Dr. Hemangi Warke.
Yes, sir.
Now the patient wants an MTP. The patient has severe aortic stenosis. Would you like to take, and symptomatic, would you like to go ahead with the MTP, or would you like some ballooning to open or to reduce the gradient and then take it? Do you have any concerns about that?
Yeah, since this patient is a severe mitral stenosis, I feel doing a BAV would be better prior to the MTP. Performing the MTP by itself without a BAV could pose a significant or it could be unsafe hemodynamically for the patient. Doing a BAV, maybe the hemodynamic parameters would improve and she would tolerate the anesthesia as well as the procedure better. So I think doing a BAV was a better idea rather than just going ahead with the MTP. Though both has its risks, any such case, the treatment should be individualized, taking into consideration even the cardiac anaesthetist, taking their viewpoint. But I think doing a BAV was a good idea in this patient.
So, yeah, I think that, thank you, Dr. Warke, you made a point. Maybe there are people who may disagree because the opinions can be different, but what the message that the audience need to carry is that medical termination of pregnancy in a woman with heart disease is not a safe procedure. The risks are always high. In our MPAC registry, Madras Medical College Pregnancy and Cardiac Registry, the complications associated with the medical termination of pregnancy was almost 11%. So it is not that easy, but maybe 10 weeks it may be better. But still, we have to understand that we have to be we take all the precautions for it. Dr. Charan, what will be the ideal time to intervene in a patient, if you want to do a balloon aortic valvotomy? Supposing, let us assume that this patient wants to continue the pregnancy. In either case, if she wants to terminate now, you'll be going to do it right now. If she wants to continue the pregnancy, when would you like to do the balloon aortic valvotomy?
Ideally, by choice, I think second trimester is the best period for doing the balloon aortic valvotomy or any kind of procedures, because already most of the organogenesis and neural development has occurred. And what we had a problem, generally we think about radiation induced issues, so those will be less. So that is a better period. Also, the hemodynamically patient would be better in the second trimester to do. So I think after about 12 weeks, mostly after 14 to 20 weeks, that's a period when we do the balloon aortic procedures in the second trimester. But yes, if the patient becoming symptomatic or any urgency arrives, it should be done as early as possible, and then thinking of trimester would not be the issue here, because first of all, mother comes the first for saving the mother in that case.
Thank you, Dr. Charan. That was a valid point. You said that one more question I'll ask you is, how much is the maternal risk of this procedure?
If at the best center with the best operator in the cath lab, I think maternal risk is some up to around 4 to 5% according to me, which includes the chances of heart failure if the overload has happened, or the incidence, the procedure related complication and non-procedure related complication. I will label that. In procedure related complication, you could have vascular issues, or the significant aortic regurgitation, maybe a more than moderate AR. That's a complication, but it can occur less than 1 to 2% cases. So precautionary, the cardiologist, dilate the wall with lesser CC, maybe 80 to 90% of the sizing we do. So that's a precautionary approach in those cases to avoid such kind of complication.
Thanks a lot, Dr. Charan. So the thing is, Dr. Kailash Bhatia is a good friend of us. He's an obstetric anesthetist. He is in UK. He has given some inputs here, and they're very pertinent to look into. So what he says is that now, if you say 4 to 5% of maternal risk associated with the balloon aortic valvotomy, the surgical termination of pregnancy doesn't have that kind of risk. Why would you not consider a surgical termination of pregnancy and then send the patient for a definitive procedure? I think I agree with you, Dr. Kailash. There is a very valid view also. But, as I think Dr. Himangi pointed out, every patient, it is an individual decision based on the expertise available there. Probably with Dr. Ajay Mahajan and Dr. Charan holding, sitting there in the cath lab at KEM with a lot of experience, the risk of procedures, they would have thought it would be much less, and they successfully did that. Very thanks a lot, Dr. Kailash, for that point. It's a very, very valid point. We should not forget that, interventions during pregnancy is it has its own associated risks. Thanks a lot. Dr. Ajay Mahajan, are you there? Can we ask a question to you?
Yes, sir, I am there.
Okay. If possible, you can switch on your video. So my question to you is that what is the fetal risk during radiation exposure, and what are the radiation safety precautions? I think you did this case. So maybe
actually the fetal risk totally depend upon the duration of gestation. If we are in the second trimester, the chances of risk is less because the organogenesis is already there. But if we are prior to 20 weeks, then chances of teratogenicity is very high. But if the radiation is restricted, you have to take a proper precautions. You have to put radiation protection laid aprons around the womb, around the waist of the mother, and over the abdomen, so that the radiation is reduced. Then there is a radiation absorbers also, and we have to reduce the cine angiogram. We have to go with a pulse fluoro. Don't do excessive fluoroscopy, and the risk is significantly reduced if the total dose is less than 50 gyrans.
Thanks a lot, sir. I think very quickly you gave a lot of pearls for radiation safety, particularly during pregnancy. Now, we have taken this procedure for an empty BAV. Definitely an cardiac anesthetist would have been there, and would have done an MTP, and obstetric anesthetist would have been there. Now we have our anesthetist from KEM, Dr. Sanjeeta. I have one or two questions for you. What will be your procedure of choice or method of choice for anesthesia during MTP, and what are the parameters that you'll be monitoring during MTP?
The choice of anesthesia will be general anesthesia,
And for that, we can go for the total intravenous anesthesia or the combination of inhalational anesthesia plus the intravenous anesthesia. While administering this anesthesia, one has to consider that this is a symptomatic aortic stenosis, severe aortic stenosis patient. So our goal should be to maintenance of preload, the maintenance of heart rate as well as rhythm, and we have to take care that the systemic vascular resistance should not be reduced and after load to be preserved. So it should not be increased so as to have an effective cardiac outcome. And these patients are mainly dependent on the LV diastolic feeling on the preload. So there should not be any tachycardia. So that analgesia as well as any surgical anesthesia should be taken care by our anesthesia techniques. And the monitoring is very essential in this. So we will have the routine monitoring like the ECG monitoring and NIBP monitoring. If she is still in breathless and the NYHA 3 or 4 bed, one can go for the at least arterial the monitoring, the pressure monitoring, where you get a bit-to-bit variability of the pressure.
Thank you, Dr. Sanjeeta. There are a couple of more comments in the chat box. Thanks a lot, audience. We really appreciate that. I think Dr. Vinod has commented that BAV has been done ultrasound guided with minimal fluoroscopy. Of course, it has been done. But in the routine BAV also, the fluoroscopic dose, if the appropriate precautions are done, it is much less. So, it's in a pregnancy, it is more safer. I'll rather prefer to use more fluoroscopy. Of course, I'll prefer to use echocardiography to reduce fluoroscopy, but not an exclusive echocardiographic procedure. And Dr. Mahajan, you wanted to comment something, please?
So the most important thing about the fluoroscopy during aortic stenosis is maximum time is taken for the crossing of the aortic wall. So that can be reduced by just pacing the ventricle at a higher rate so that we can cross the wall very easily at a lower blood pressure. And then after crossing the wall, then at the time of dilatation also we have to go with pacing the ventricle at a higher rate.
Thanks a lot. I think there is a very useful tip to the cardiologists who are doing the procedures here, because in a patient like this, the patient's LV systolic pressure was 235. So whenever you can enter the aortic valve only when the aortic valve opens. When it opens, you find the LV pushing everything out at a pressure of 235 or 250 millimeters of mercury. So when you pace it rapidly, the pressures are going to come down. The resistance to the wire to enter the LV is going to be less. You may be able to enter the LV better. And radiation, of course, fine comments are there. Any changes done with the flame? Of course, flame rate, obviously, they would have come down to 7.5 and sometimes 3.75 as well. During pregnancy, routinely 15 is not taken. 15 frames per second is not taken. So, our Dr. Uday.E.Jadhav, is he there, a cardiac surgeon?
Should be there.
Yes, sir.
Yes. Oh, okay. Fine. If you can, please switch on your video. Let the audience have the pleasure of seeing you, the famous cardiac surgeon of KEM. And what are the indications of surgical aortic valve replacement during pregnancy? And maybe what will be the right time for you to do? And maybe you can share some of your personal experience as well. Dr. Uday, are you there? Maybe if your bandwidth is good, maybe you can stop your video. Bandwidth is not good. We'll... Yeah,
Hello, sir.
Yeah, now you are audible. Maybe we'll just wait for again, sir. Maybe you can just, even the next break, we can come to answer. And we'll go back to the case. Annie, you can present the slides.
So these are the films where we did the procedure. Professor Dr. Mahajan was the operator here. So in the fluoro film, you can see that the use of radiation protection, lead plate was put for radiation protection, and With minimal fluoroscopy,
Dr.
the
Bhavik,
valve was crossed. Yeah.
Dr. Bhavik, just one point I just wanted to share here. Some of the operators, particularly during pregnancy, they use a very long sheath that goes almost up to the left subclavian artery. The idea is that you can exchange the hardware with less fluoroscopy there. So this was also suggested by Dr. LKM in his recommendation, but not many use that. Some do use that. Please go ahead, Dr. Bhavik.
Next slide, please.
Next one, Annie. Next slide.
So after crossing the aortic valve with straight tape pteromoglide wire, Safari extra small wire was exchanged, and then under rapid atrial pacing, the balloon inflation was done. So here, as we had previously discussed, that our goal was just giving a bridge towards the termination of pregnancy and not at all giving a therapeutic relief from aortic stenosis. So even though the annulus of aortic valve was around 21 millimeter, we used 18 millimeter Atlas gold balloon. So the main purpose was that we would leave the gradients, we would decrease the gradient, but not give the full relief of aortic stenosis. That was the plan, so that the main purpose of palliation, can be given to the patient. So next slide, please. So here you can see that earlier the gradients were around 200 millimeter of mercury, and they have gone down to 187. So here is the table which showed the hemodynamic data pre and post BAV. The LV systolic pressure pre-BAV was around 250 millimeter of mercury. That has gone down to 190. Aortic pressure was 93 millimeter of mercury pre-BAV. That had gone up to 110. Transaortic gradient had almost halved. So earlier it was 162, which had gone down to 80. And diastolic pressure, EDP was 38, which had also halved to like 20. So that was the whole plan, and we think that we succeeded in executing that plan. Next slide, please.
Yeah, I think some of them answered this question. You can please maybe share the poll, but they don't answer all the whole stuff again. So go back. Yeah, we'll just discuss this poll. After balloon aortic valvotomy, the gradients are still unsettled. Can we proceed with the MTP now or continue high-risk pregnancy? Both may be the options. And now I think if you want to discuss that, because the gradients have come down, you can still proceed with the MTP, not an issue at all. I'm sure her symptom status, the question doesn't cover the patient is symptomatic or not. The patient is asymptomatic, then whatever we discussed about that, whether we can probably subject her to an exercise echo, maybe 2 weeks down the line, in case she wants to continue the pregnancy. And if exercise echo, BNP, all the parameters are good, probably we can just consider continuing the pregnancy and then probably do a hybrid LSCS and surgical aortic valve replacement. That's also a possibility. So then we'll go to the next question. Meanwhile, I think Dr. Kailash has asked one more question. Dr. Chandrabar Meena has said that gradients are still high, can terminate pregnancy. Of course, KEM Mumbai had done the same thing. But the other thought is the gradient has come down to 80, which is less than 100, according to Chandrapan Meena's criteria itself. We can definitely subject her, if the patient wants to continue the pregnancy, to an exercise echocardiography, BNP, and then evaluate and then take a call. Now, if the patient's valve was calcified, or if the patient had a moderate or a mild aortic regurgitation, mild to moderate, so what will be the team's plan is the question that Dr. Kailash has asked. Now, of course, if the patient has a non-dilated, calcific aortic valves are not amenable to balloon aortic valvotomy, but this is not something we usually see in pregnancy. In pregnancy, particularly in the Indian scenario, since they are younger women, we don't find calcific valves, but of course, associated aortic regurgitation does not allow us to continue the safe pregnancy, in which case, if the patient is too sick, transcutaneous aortic valve replacement, TAVR, may be considered. Or if the patient has presented to us by 28 weeks of pregnancy, A surgical aortic valvotomy, valve replacement, along with the LSCS in the same operating table can be considered. Transcutaneous aortic valve replacement, lesser number of cases are reported, and particularly in younger patients, we need to consider the lifelong management of aortic stenosis. So, personally, I'll prefer to consider a surgical aortic valve replacement, but for the fetal safety, TAVR will be more safe than a surgical aortic valve replacement. Can we move forward to the next slide? Dr. Bhavik, please.
Was a termination of pregnancy that was planned to be the underwent validation and however, the charts of the according to the patient and discussion, the termination of so
Your bandwidth is less, Dr. Bhavik.
Bhavik, your voice is not clear.
Maybe you can stop the audio.
Yeah. Is it audible now?
Yes, it is better now. It's better now.
Yeah. So the patient was advised for termination of pregnancy as was the plan. She underwent dilatation and curettage under TIVA after BAV and was advised surgical AVR. However, the choice of surgical valve was to be decided according to the patient preference and heart team discussion. As we previously discussed, that this was the termination of pregnancy. She has not conceived full-term pregnancy till now, and considering she was offered postpartum counseling and contraception.
वो तो balloon किया था. Midas.
The next slide, Annie. Yeah. So now the patient has been discharged and advised for a surgical aortic valve replacement. Now let us come back to the discussion table. So I'll ask Dr. Hemangi, what is the ideal contraception for this patient after MTP? Now, many times we send the patient after MTP and we plan a procedure a little later, but before that they come back pregnant again. So it is very important that we advise them the necessary contraception. So what will be your ideal contraception in this patient? You are muted, Dr. Kansaria, you are muted.
Sir, since this patient has no living issue, she has not finished her family, then either a barrier contraception or progesterone only pill or progesterone only injectables or implant, they are the prefer. We'll give the option to the patient. We cannot give estrogen containing pills since it causes thromboembolism, especially in patients with heart disease. So barrier, progesterone only pill, progesterone only injectable or progesterone only implants. These options are given to her, whatever she chooses. Progesterone only pills, basically they are contain either norethistran or norgestrel, and they are started on first day of the menses. Injectables, there are injectables available, 150 milligram Depo-Provera, which is given every 3 monthly to the patient. So depending on whatever she wants, we can advise her the contraception.
Thank you, Dr. Himangi. If you look at this Indian scenario, the same patient, she had a pregnancy in 2023. She was advised termination. She had the medical termination of pregnancy, but it should not come back for follow-up. She has come back again in 2025 with the pregnancy. So this is a very common scenario in India, particularly in the below poverty line or the patients, those kind of patients who come to the government hospitals, that they don't really follow it up with the contraception. So it becomes imperative on us, who are providing the healthcare for these patients, to ensure that these patients are followed up and given the adequate contraception and also given the definitive procedure. If we probably had a big team that was looking after this patient in 2023, whichever hospital she was treated, she could have got a surgical aortic valve replacement, and probably subsequently she could have gone or even a trial balloon aortic valvotomy. Something could have happened, but unfortunately, we don't really have a system like that in most of the hospitals where we keep on following up the patients. And next question to Dr. Charan. Now the patient has an MTP. How would you optimize this patient's cardiac condition before a subsequent pregnancy. She has a primary, she doesn't have a live child, so obviously she'll want a baby. So what will you advise them? Will you advise a balloon aortic valvotomy? Will you advise a TAVR? Or will you take a surgical aortic valve replacement?
We need to discuss with this patient, relative and the obstetrician. First, foremost thing, whether she wants another pregnancy, whether she wants a child or not in this case, probably she would in this case, as there is no life birth at that time. So important thing is, after this MTP, we will offer her, we'll console her about having the normal pregnancy or the period of time, what period she can have it, and what is the possibilities we can offer her. Most important, having another baby in this patient less likely will cause any much relief in the gradient, as we have shown this case as a balloon aortic valvotomy, the gradient fell from 160 to 80. So probably doing again a BAV will not be so much successful in this patient, probably because of wall anatomy. It could be a thicker wall or a mildly calcific wall. So option remain for us is surgical kind of a aortic valve replacement. And now again, in surgical aortic valve replacement, we have two choices, either a bioprosthetic wall or a mechanical wall. So if she wants to have another pregnancy, bioprosthetic wall is the best choice for this patient. And if she has completed the family, if she says that, no, I don't want to carry the children later on or have kids, then yes, mechanical valve can be best. Again, we have to talk about the risk of coagulation, risk of bleeding on potential anticoagulation if she goes on the mechanical wall. But for this patient, I think best would be having a bioprosthetic wall. As far as TAVR is concerned, there are very less case reports. All are not from India, all are from out of the India, maybe 7 or 8, which I could see in the research database. And in a native wall, only 1 or 2 cases have been reported. However, in the bioprosthetic dysfunction of the wall, there are 7-8 cases. So I don't think at present there is enough data to say that probably TAVR is better in this kind of patient. We need to have a better in over maybe a decade follow, we'll be able to answer that question. I think TAVR can be indicated in a patient where we cannot do a palliative kind of a BAV. In that kind of patient, you could consider probably that yes, and if there is no financial problem. So there are a lot of technical issues also with the TAVR in those, because even the radiation dose and everything will be higher in that patient. So I think that's my overall.
Dr. Ajay, please. Professor Ajay.
So the most important thing is that the pregnancy, so the age group where the patient become pregnant is up to 45. And TAVR is the only therapy after the age of 65. It should be given once in a lifetime because the durability of the wall is not more than 10 years. So the TAVR should not be an option in this case. In this case, after MTP, one can go with because we are having some limited resources. Here, in this case, we had gone with a 1:0.6, 0.6.5 dilatation, because we don't want acute aortic regurgitation because left ventricle was very small and there was severe aortic stenosis. So that was our concern. So now when we have to plan this particular case subsequently, we can do that. We can take this case as the first case for balloon aortic valvuloplasty, morning first case, with the active CVTS standby. Everything should be ready in the cath lab, in the operation theater. If the aortic gradient is not coming down less than 30, and if there is a significant aortic regurgitation, patient will go for aortic valve replacement. If the balloon aortic valvuloplasty is significantly improving the gradient without any problem, then we can halt there and the patient can continue on a medical management, and subsequently she can go for planning the pregnancy after 3 to 4 months of the follow-up after balloon aortic valvuloplasty. And if she is going for aortic valve replacement and she want to go for pregnancy, then it should be a bioprosthetic aortic valve. And subsequently, after 10 years or 12 years after degeneration of the bioprosthetic aortic valve, she should go for a redo surgery with a metallic valve rather than going for TAVI, because her age will be only in the range of 35, 40, 45.
So thanks a lot. I think you really made a very practical point here, because this TAVR is an percutaneous valve that is implanted through the femoral arteries, and no surgery is required. The patient can go home the same day, or even the same day or next day, or in 2 days' time. So this is commonly being done, as Dr. Ajay Mahajan pointed out, above the age of 65, 70, not in young patients. But there are case reports done in the world, and when particularly as a palliative procedure, and one or two cases I think have been done by some of the surgeons, I mean our operators in India, but unfortunately they have not published it. They have spoken to me about that. But the point that I think is very important is that you will have to do something more in 12 years or 15 years. You have to put another TAVR valve in that, or taking away a valve that has been put in another valve is going to be, the surgeons who are operating a patient with TAVR, they often say that it's very, very uncomfortable to do that. So I fully agree with the point. I think Dr. Chandraban Meena also had pointed out that TAVR is not something that is to be done on this patient. So thanks a lot. Now we have a hypothetical situation. This patient, supposing she continues the pregnancy. Now the balloon aortic galvanotomy was done, and the gradient has come down from say 160 to 80, and she is asymptomatic. Echo showed, stress echo was normal, BNP was normal. She was allowed to continue the pregnancy. She has now come to you at 36 weeks. What will be the ideal mode of delivery, Dr. Kansaria? Dr. Himangi, what will be the ideal mode of delivery that you will have?
Sir, ideally it depends upon case to case. Like we had one patient in our institute for whom LACS was done, cesarean was done in a case of severe aortic stenosis. But otherwise, if she is the severe, it's not severe. If it's not a severe aortic stenosis, then she can go in labor. She should kept in basically propped up position. Vitals parameters should be monitored frequently between contractions. If pulse is more than 100, respiratory rate is more than 24 beats breaths per minute, and associated with dyspnea may suggest impending ventricular failure. And for anesthesia, I think epidural is better anesthesia. And hypotension, if it occurs, it can be life threatening. But it varies depending upon case to case.
Thank you, Dr. Hemangi. Dr. Our Mahajan sir is there, Dr. Mahajan. If the patient is going for pregnancy, what do you think will be the complications that you will be anticipating intrapartum and postpartum? As a cardiologist, what will you expecting it or anticipating it?
See, this case of severe aortic stenosis with a bicuspid aortic valve, so most of the time there is aortopathy, and the chances of getting aortic dissection at the time of second stage of labor are very high. So all these patients should be gone for elective LSCS. Second thing is that during elective LSCS, it should be general anesthesia and not spinal. If you want to go for spinal, then you have to go for epidural only. That is the another thing. And the third thing is that these patients may get exaggerated symptoms of syncope and some stroke-like things during labor. So we have to go for elective LSCS as soon as the viability of the fetus is achieved.
So thanks a lot. I think you gave all the points very crisply, and you also touched upon Dr. Sangeeta's point about the anesthesia.
Yeah.
So please go ahead, Dr. Sangeeta, our anesthetist.
Yeah,
I will
yes.
ask you, what will be the choice of anesthesia and
Yes.
analgesia in this patient during delivery? Now, this patient, I think doctor made a very valid point, because it's a bicuspid aortic valve, severe aortic stenosis. It is not the other aortic valves. It's a rheumatic aortic valve. You don't really get the chance of dissections are much, much less. Whereas in bicuspid aortic valve going through the pregnancy, particularly severe aortic stenosis with aortopathy, there is about 0.5 to 0.8% chance of aortic dissection. So cesarean may be a better option than vaginal. Now, if the patient goes for a cesarean or a vaginal delivery, what will be your role as an anesthetist to support the patient?
If it allows to go for a vaginal delivery, then we may consider about the labor anesthesia in terms of neuraxial anesthesia with intrathecal opioid, which will not cause a hypotension, which we are worried about in these cases, and epidural labor anesthesia, where segmental blockage we can achieve, and there will be hypertension. If it at all it occurs, it will be a slow, gradual hypertension. So we can take care of that by maintaining the SVR with the small aliquots of vasopressors like phenylephrine or so. And the same can be converted for the surgical anesthesia, that epidural anesthesia, taking care of the deleterious effects of this neuroaxial anesthesia, maintenance of preload, maintenance of the SVR, all these points. So here the epidural anesthesia will help to maintain the heart rate so as to reduce the deleterious effects of the labor. If this patient goes for the cesarean section directly, the elective LSCS, then the again, if she is having the, as you said, that the bicuspid aortic wall and there are the chances of dissection, so then the general anesthesia will be a preferred choice with the monitoring the ASA, the standard monitoring, and additionally at least arterial line monitoring, with where you'll get a bit variability, and where also can get a guide to administer the fluid in terms of pulse pressure variations and kind of thing will help to administer the fluid so that it won't be a overload as well as the low preload. So both things can be kept.
So thanks a lot, Dr. Sanjeeta. Now, Dr. Uday.E.Jadhav, are you there? Is your video or audio good? I just would like to ask you if she goes for a bypass surgery,
Yes, sir.
bypass. Yeah. What will you do, or what are the concerns about? Because the fetal risk, of
Surgical
course, of
aortic valve.
cardiopulmonary bypass, the fetal risk is quite high. So, what can you do to mitigate the fetal risk during a cardiopulmonary bypass? Dr. Uday.E.Jadhav, are you there?
Voice is not audible, sir. So can I have some word regarding if his voice is not there on CP bypass, the consideration?
Yeah. Meanwhile,
Yeah,
Dr.
yes.
Manokant, an anesthetist from Fernandez Hospital, he has given low-dose CSC with invasive monitoring vasopressor inotropic support as a viable option for anesthesia, even when patients severe AS. I do agree, and cesarean birth for severe aortic stenosis has been suggested in ESC as per Dr. Kailash. And I think before we go into the carry home session, Dr. Sanjeeta, a quick comment from you. You wanted to say something, please go ahead.
Yes, this is regarding cardiopulmonary. When the mother is subjected to the cardiopulmonary bypass, then the maintenance of the perfusion pressure to the higher side, the normothermia, and maintenance of good hematocrit will be the treatment options to consider the to reduce the fetus at risk and the continuous monitoring of fetal heart sounds. So, and as well as there should not be any metabolic acidosis. So the oxygen dissociation curve should be on the right side. So the fetus will not have any hypoxia.
Thanks a lot, Dr. Sanjeeta. Now, maybe Dr. Charan, yes.
Yeah, I just have to one comment. In a peripartum period, with the patient is continued to do the for a pregnancy and delivery, basically I think most important complication which could occur is decompensated heart failure. I think that's a devastating complication. Is very common as compared to the aortic dissection and as compared to the sudden cardiac death, which we clinically see. So that was one comment from my side.
Yeah. Auto transfusion, because of auto transfusion.
So thanks a lot, Dr. Charan. We'll just go to the carry home thoughts. Yes. Maybe another 5-10 minutes, a quick lecture. This basically, this is a common etiology that we see of severe aortic stenosis in India. Commonly, it is most commonly rheumatic. In developed nations, often bicuspid aortic valve, and degenerative aortic valve is uncommon, in pregnant population, except in those who come as elderly pregnancy. As you can see that severe asymptomatic aortic stenosis is MWHO class 3 And the present patient is severe symptomatic AS, which is WHO class 4. Moderate aortic stenosis, the pregnancy risks are very, very less, and they can go through safely a pregnancy. So what happens during pregnancy? You find that the period of maximal cardiac output is around 24 to 28 weeks. And this is the time what happens is the transaortic gradient increases a lot. The left ventricular end diastolic pressure increases, LA pressure increases. Because of that, the symptoms of aortic stenosis like heart failure, chest pain, and syncope, they become more prominent. So on an average, if you look at moderate aortic stenosis, there is a less than 10% of patients going to mild heart failure, which can be comfortably managed. Whereas in severe symptomatic aortic stenosis, almost 1/4 of them, they go in for heart failure. And as Dr. Mahajan pointed out, in balloon aortic valvotomy, aortic dissections can happen, particularly, in bicuspid aortic valve, aortic dissections can happen. And fetal risks are definitely higher. IUGR and low birth weight as such as 40 to 50%, and preterm births are commonly noted. This is the largest data as of now on severe aortic stenosis or moderate from the ROPAC data. 96 patients with moderate or severe AS, not a single mother died. That is a good news. We have to remember that before taking this patient to any high-risk procedure during pregnancy where there is a risk of mortality. So heart failure happened in 26% of the symptomatic patients and 7% of the asymptomatic patients. The majority of the time of heart failure is between 27 to 28 weeks where the cardiac output is maximal. In our Madras Medical College pregnancy and cardiac disease data, the largest single center study in the world, we find that we had only 15 patients with severe aortic stenosis and none of them died. All of them had a safe delivery. 2 mothers had a heart failure which could be comfortably managed. So when you're echo assessing a patient with aortic stenosis, the cardiologist, we have to remember that the peak velocity and the transaortic pressure gradients increase by almost 50%, whereas the aortic valve area is more stable. So it is better to go by aortic valve area than by pressure gradients in these patients. Now, what to do if a patient with severe aortic stenosis comes to us in the preconception period? If the patient is symptomatic in the preconception period, there is no question at all. Symptomatic severe aortic stenosis, they need a definitive therapy. A surgical aortic valve replacement will be the best choice. If the patient is asymptomatic, if we can do an exercise stress testing, if the exercise stress testing or the exercise echo is normal, they probably can go through the pregnancy. As you can see that the aortic stenosis is non-severe, the patient has no symptoms, the patient can go in for a pregnancy. If the aortic stenosis is severe or the patient has symptoms, the patient has to have a surgical procedure before she goes in for a pregnancy. If the patient has no symptoms with a severe aortic stenosis, we do all these testings. If all the tests are normal, we can allow the patient to go through a pregnancy. Now, if the patient is coming to us for the first time during pregnancy, what shall we do? The patient is coming to us for the first time during pregnancy. If the patient is asymptomatic and has a normal LV function, we follow them up, avoid strenuous activities, support them through the pregnancy. If the patient has mild heart failure symptoms, we can manage them by medications, restricting the physical activity and diuretics. If the heart failure is not responding to drugs, a balloon aortic valvotomy to delay the surgical valve replacement till postpartum can be done. This is a palliative balloon aortic valvotomy. However, if the patient heart failure symptom persists despite valvuloplasty, or the patient is not eligible for valvuloplasty because of severe calcific aortic valve or significant aortic regurgitation, the patient will need to go for aortic valve replacement during pregnancy. So this is how we manage a patient with aortic stenosis during pregnancy. So the concerns about when we take a patient for a balloon aortic valvotomy during cath lab, we find that most of the organogenesis happens within 2 to 8 weeks, and the neuronal stem cell proliferation happens within 8 to 14 weeks. And these are the complications that generally happens, and the dose of thresholds are given to you. So during pregnancy, Less than 5.5 millisieverts per month is allowed, and fetal radiation less than 50 millisieverts is technically negligible. So for those who are not cardiologists, you see that this is the X-ray tube that generates the X-ray. This is a normal person. We put them here. We put these shields to protect the patient, doctor and the staff from the radiation. In a pregnant patient, we put a shield under the back of the patient to prevent the radiation safety. There are some operators who used to use a a shield on the top of the abdomen, but what has been recommended is that not to use this top, because what happens is the scattered radiation get reflected by it and get back into the fetus. So I practically do not use nowadays. Earlier I used to use this shield on the abdomen. The last couple of years I don't use it during pregnancy. The bottom shield is fine. What will be a good time for pregnancy? We need to consider these points. Definitely fetal radiation risk has to be considered, definitely not before 16 weeks. Also, we need to consider the mother's ability to tolerate the disease. Now, we cannot wait till 32 weeks or 30 weeks, so the mother is severely symptomatic at 16 weeks. And the fetal survival in case of a premature delivery. Now, if the patient you are taking it at 24 weeks, if it's a preterm delivery happens soon after the procedure, which sometimes happens, and the uterus starts contracting during soon after procedure, we had almost 4% of our patients had a uterine contractions, though we managed 3 of them except one with the drugs. So we have to manage that. And when it becomes 32 weeks plus, it is difficult to take the hardware through the inferior vena cava or the aorta, particularly with a large uterus, lying over it. So having all that, my preferred timing is somewhere between 24 to 28 weeks, and particularly in patients who are very sick, where I think the patient may go in for a preterm delivery. I prefer 28 to 29 weeks because the viability of the fetus is better during this period. Now, if a patient comes to us with aortic stenosis, this chart is a very good chart shared by Dr. El Khayyam. If the patient has a mild to moderate aortic stenosis, they can proceed with the pregnancy. If the patient has severe aortic stenosis and the patient is asymptomatic with the LV ejection fraction more than 50 and a normal exercise test, they can proceed with the pregnancy. If the patient is asymptomatic but reduced ejection fraction, valve interventions are necessary. If she is symptomatic, EF more than 50, definitely valve interventions are necessary. Now, native valve and bioprosthetic valve, I think Dr. Mahajan is very clear to the point that he prefers native valve. Though in the West, there are people who are advocating bioprosthetic valve, but my personal choice is still native valve during pregnancy. TAVR, of course, I think the operators are very clear. It's not the first line, and very rarely SAVR. Balloon-aortic valvotomy is the preferred one during pregnancy, but this is more of a palliative procedure than a definitive procedure. Now, this was the first time balloon-aortic valvotomy is done during pregnancy. Dr. Annie shared this slide, 1991. And these are a couple of case reports. A lot of cases of balloon-aortic valvotomy has been done. And in Madras Medical College, in Madurai Medical College, Madras Medical, in Tamil Nadu, in private hospitals, in KEM, all over India, I think people are doing balloon-aortic valvotomy in pregnancy. That is perfectly fine. So one slide, I think, to share with the procedural tips. Retrograde is always better, and long sheath, as I told you, just below the left subclavian artery, facilitates catheter exchanges and reduces radiation. And Dr. Mahajan pointed out 50% reduction, and Dr. Charan also pointed out in the gradient is good enough. We don't really want a great reduction. Just like in balloon mitral valvotomy, we don't really want a gradient more than 2. Valve area more than 2, not even 1.5. 1.4, 1.5 will be sufficient to take the patient safely through a pregnancy. So we are not very ambitious when we are doing a balloon-aortic valvotomy or mitral valvotomy during pregnancy. We start 2 to 3 millimeter less than the annulus size, and if there is an aortic regurgitation developing, we abort the procedure. Femoral closure devices reduces the bleeding complications. TAVR, I think we had extensive discussions. This is not the first line therapy, it is very clear. And if there is something very life-saving, emergency TAVR has been done, but then lifelong management is a very serious consideration. I think all the senior professors pointed that out very clearly. Surgery, we are not able to get Dr. Uday.E.Jadhav's voice most of the time, but he shared that what are the indications? In the preconception, severe symptomatic aortic stenosis or asymptomatic aortic stenosis in the positive exercise test, or asymptomatic severe aortic stenosis in the patient wants it. During pregnancy, severe symptoms resistant to medication therapy and not amenable to balloon aortic valvotomy. Timings, well, immediately after delivery or around the delivery time, particularly when you're planning a cesarean and aortic replace on the same operating table, the cardiac surgery, the best period between 13 to 28 weeks is what ESC guidelines say. This is where the maternal fetal safety. Maternal risk is about 3 to 7%. Fetal risk is prematurity is high. So take home, just to share with you, moderate and mild lesions, they share very well pregnancy. Severe asymptomatic lesions also do reasonably well in pregnancy. Cardiac interventions during pregnancy are less often needed, and good to involve a senior experienced operators in the procedures, and cardio-obstetric team approach is extremely important in planning the procedure. With that, I stop here, and any comments we can take, any questions we can take. But before that, I sincerely thank the team KM Mumbai. KM Hospital Mumbai is a premium leading hospital all of you are familiar with. They are a part of the National Pregnancy and Cardiac Disease Study, which is a national study ongoing in the country in 56 sites in 25 states. And we are developing a protocol for managing women with heart disease during pregnancy. And all these experts are a part of that study. Sincere thanks to Team KEM, Professor Ajay Mahajan, Professor Charan, Professor Hemangi, Professor Himangi, and Professor Sanjay, and our surgeon as well. Sincere thanks to you. And thanks to our team and Dr. Annie and our presenter. Sincere thanks a lot. We'll stay for a couple of minutes for any comments or any discussions.
Sir,
sorry, unmute yourself, please. Unmute yourself, please, Dr. Charan. Unmute yourself. Unmute, yeah. Unmute, please.
Yeah, it's unmuted. So practically speaking, we generally don't do the BNP or the NT-pro BNP in a preconceptual, either in the pregnancy or that age. So do you guys really do those tests when you decide really the risk of the procedure, or as a cardiac enzymes as such?
So we started doing it more lately, and particularly when we want to safely continue a pregnancy, an asymptomatic pregnancy with a good 6 minutes walk test and a good exercise tolerance, say NT-proBNP, which is normal. These are all very, very helpful.
Another thing is like, as already we have spoken about, I think exercise stress test difficult to do in those females who really they don't want to do. So in that case, they are all, most of them are anemic. They want, the functional capacity is less. So in those cases, I was going through, the CPET was advised in most patients, but again, the availability of CPET at multiple centers is not there. So practically speaking, more on the patient functional status, we decide the symptom and the things.
So thanks a lot. And Dr. Kailash has shared one paper in the group, Souza et al. By managing a severe aortic stenosis during pregnancy. Thanks, Dr. Kailash. I think there's a meta-analysis. Please, audience can go through that. We'll also get that article and share it in the Cardio-Obstetrics group. For those of you who could not see or see the earlier versions, is available in the Cardio-Obstetrics India YouTube channel, and this video also will be uploaded in the channel. Dr. Annie, over to you for your closing remarks. Yeah, Annie is not here. Annie,
Yes,
are you there?
So thank you all for joining together in this Cardio-Obstetrics Masterclass. We look forward to see you again next month. Until then, we wish you a blessed month. Thank you.
I think the next time it will be by AIMS New Delhi. AIMS New Delhi team will be presenting. We'll be looking forward for their presentation. And KEM, you really did a great job. Thanks a lot.
Sir, you have beautifully chaired and directed the whole show. It was excellent one and a lot of great questions, practical questions, and the input from Dr. Mahajan and everyone from our guest, the obstetric team and anaesthetist was great. Thank you very much for giving an opportunity for this case, sir.
Questions were designed by Annie. I should.
Yes, absolutely great one. Thank you, Annie.
Thank you.
Thank you, everyone. Yeah. Thank you very much, all. Opportunity. Yeah. Thank you very much, Paul, sir, and Annie.
Compile this and all the questions asked and share it as a small, a summary booklet, not booklet, a pamphlet, so that all the questions asked and the answers will be given. We'll share it to you very soon. Thanks a lot. Thank you so much.
Thank you.
Thank you very much.
Thank you very much.
Thirty-one.